A very warm good morning to everybody. First of all, I would like to thank Dr. Amit, who has invited me to be part of his team. SICs in compromised cornea essentially for most of the cases which we see essentially means a lot of gut tear. Pre-operative evaluation is very important because cornea is one thing which we definitely tend to miss out when evaluating for cataract surgery, and it's essential that we look for carefully for gut tear. And second, as Dr. Ganesh has just pointed out, pseudo-exfoliation, which is quite obvious. And so these two form the majority of the bulk of cases of compromised cornea as such. Apart from this, posterior polymorphous dystrophy, sometimes rarely post-keratoplasty cases or post-trauma cases wherein the endothelial count has come down. And also when the other eye has got corneal decompensation, we have to be very careful. And add to this, there are a lot of compounding factors which really complicate our surgery. And I would grade shallow anterior chamber is one of the most difficult aspects or a problem to tackle when we are doing SICs in a compromised cornea. Of course, there are others like deep socket, small rigid pupil and brown cataract, etc., which has been extensively been dealt with. And another clue to a stormy surgery would be other eye's decimus detachment. If the other eye cataract surgery has had a decimus detachment, then be prepared for some sort of that problem in your case also. So, in compromised cornea, we have to assess the degree of corneal decompensation. It can be arrived fairly by a meticulous history which shows some amount of diurnal variation in vision. And corneal thickness and specular, they don't have magic numbers as to when the cornea will decompensate, but it gives a fairly good idea if you have an access to this. Always early surgery is better. For example, the picture shown below, in such cases, you can proceed with surgery and probably come out of it without any problems. And in all cases with corneal decompensation or problematic cornea, always have a detailed discussion with the patient that you may have a delayed visual rehabilitation because the edema might persist for a long time, and also a possible decompensation. And if it's severe as in this case, then probably it would be wiser to proceed with PKP or DSEC with IOL, etc. So once you have decided to undertake SICs in your case, then probably the most important thing to be observed is to avoid any manipulation or struggle, because whenever you have a manipulation or struggle, you're going to land up in more and more problems. So all your steps should be directed in such a fashion that you preempt these problems. So what exactly are these problems? One problem is avoiding or managing the positive pressure. That can actually make or break your surgery. It becomes very difficult once there is positive pressure. Secondly, to have a well-maintained anterior chamber. Third, to sustain a pupillary dilatation throughout the end of the surgery. And of course, obviously, avoiding corneal contact while you're doing prolapse or delivery or putting the IOL inside. And at all times, be ready to convert to ECC. So first, how to avoid or manage positive pressure. Obviously, good block is very essential, and the adequate amount of whatever you're used to, giving lignocaine, etc., and give a good massage pre-operatively, except if you're suspecting a pseudo-exfoliation where you can land up with a zonal dialysis per-operatively, so you can do that. IV mannitol may have a role, but usually it takes a long time to act, and also in most of our elderly patients may not be a good option. So probably if you have persistent positive pressure, after you've checked the speculum and everything is all right, I will proceed with an intravitreal tap, which is an invaluable means of reducing the IOP. How is it done? Just take a 5cc syringe and put 26G needle and 4 millimeter away from the corneal limbus in the inferior and outer part of the eye in the pars plana. Just give a small tap and just take 0.1 or 0.2 ml, and the effect is really dramatic. So after you have managed that, now the key part is to maintain an anterior chamber, and obviously a well-constructed tunnel is the most important part. So tunnel construction has been dealt with extensively, so I won't be going into the videos of it, but suffices to know that the goal of tunnel construction is to have a wide and non-leaking wound, especially when you're talking about a decompensated cornea. Site of incision definitely based on the K reading, and I would always prefer a large frown incision which makes it really self-sealing, and any nucleus problem can be preempted because of that. And it goes without saying that corneal valve, there is in the tunnel, that is the most important part of the tunnel, which prevents iris prolapse or premature entry, etc. So tunnel should be long enough when you're putting in cornea. There is a case for making it a temporal incision, which gives you better glow and deep socket, but I think we are all aware that smaller and thinner limbus in the temporal part are prone to tear. So you have to be extra careful in making that tunnel, and also again making a longer corneal valve. Of course, you should not place instruments in such a way that the tunnel leaks. For example, if you're using two instruments, never cross it. If you tend to cross it, the chamber remains open, the tunnel remains open, and the visco keeps on leaking. So always try to put it parallelly, although it may not be possible in every step. And of course, use of plenty of visco at each and every step. Even in normal cases, if you land up in problem and if you feel that you don't know what is happening, whether there is a tilt, whether there is a rent, always put a lot of visco. That creates a lot of space for you to visualize and clears up the anterior chamber. Is there a case for a helon? Maybe there is a case for a higher molecular weight visco elastic. But for example, in a very shallow anterior chamber where you're starting a rhexis, probably it has a rule. But as by and large, and even in a compromised cornea, I use mainly visco. And people who have used chamber maintainer also say that there is a good case for using a chamber maintainer, although I don't have a personal experience in that. So the next thing to make sure is to have a very good pupillary dilatation, and that is to catch the maximum red glow. Even if a cornea is scarred, you have to make sure that you get the maximum red glow while doing it. Now, how is it possible? You can, as I said earlier, temporal section gives you a better glow, and positioning of the rectus is important on the chin position of the patient so that you get the maximum amount of pupil in front of you. And as Dr. Ganesh showed in his video, use of iris hooks is highly recommended. It makes the life easy. And if you do not have access to this, never ever hesitate to do a sector iridectomy. Even if you do a stretch pupilloplasty, your visibility per se is slightly only marginally increased. So if you have a very shallow anterior chamber and Brunnerson cataract or an intumescent cataract, never hesitate to do a sector iridectomy, especially if the pupil is small. You can of course use stripe and glue, a very minimal amount, taking into consideration the cornea, and always try to use it under air bubble. Next will be to avoid corneal contact during prolapse and delivery. Now this is important. Many prolapse videos have been shown, and to avoid problems in prolapse, the first and foremost step you have to do is a large rhexis. Now if you're not proficient with rhexis and you feel that probably the pupil is not good enough for a wide rhexis, never hesitate to do a can opener. Remember, can opener, you don't need rhexis for doing an SICS, but you can do a can opener, and if you end up with having a small rhexis, then always cut it open and give some nicks and make it a large one. And I always, in such cases, debulk the nucleus before starting the prolapse. It's very easy to do it with Simcoe. You just take out whatever cortical matter in and around the rhexis so that the nucleus size comes to half. And they have shown beautiful videos of hydroprolapse, but I generally avoid hydroprolapse at all because it's one uncontrolled step in your cataract surgery. If your cornea is compromised, hydroprolapse may not be a good option. What you can do is go for a bimanual prolapse. So in bimanual prolapse, you use two instruments as is shown here. What I generally use is having a visco cannula in my left hand instead of the instrument which is shown here. You can have a Sinski in your right and left hand. You can have a spatula. I use a visco cannula in my left hand and use it as a fulcrum for the nucleus to be rested upon. And on the right, with the right hand, it will be a Sinski which glides it. And the advantage of taking a visco cannula in your hand is that you keep on pumping visco in between whenever the cornea becomes shallow, when the anterior chamber becomes shallow. And again, next uncontrolled step will be a nucleus delivery, which, as has been shown, can be beautifully done by using a vectis. But the key thing to remember is that the anterior chamber should not collapse. So by the end, when the nucleus is trying to come out, you have to put a lot of visco inside the AC so that the AC is formed. So visco delivery may be a very good option in that case. If you think that you can take it out with normal saline or BSS, then once the nucleus is stuck inside the tunnel, wait for a few seconds, inject more saline so that the anterior chamber remains, and gently depress the tunnel and then slowly take it out so that the anterior chamber remains open. You can actually practice all these things in a routine case so that when you come across a compromised cornea, it becomes easier. So at any step, if you think that the nucleus is stuck or it's big enough and your tunnel is small, you have to go for a ECC. So how do you convert it? It's a fairly simple affair. Now here the nucleus is stuck and the inner lip has to be opened up, and here the surgeon is cutting both sides of the tunnel. It's not essential. If you feel that you can only cut on one side, it should be enough, because suturing is a very tricky affair, and this is a very important step wherein the outer tunnel is merged with the inner lip. This has to be done. If you don't do this step, you're still back to the same point. And so after this has been done, then it becomes easy. You have to take the nucleus gently and take it out. Make sure that you put sutures in whatever possible areas. Especially these are the corner sutures are the more important ones, and then you can fill in with other sutures. So other points of avoiding contact with cornea is always do a gentle irrigation aspiration, minimize the total lavage time. The more amount of fluid goes into the eye, the more problematic it is. Avoid excessive back flush. That is, keep on using positive pressure. Even a jet of positive pressure, the fluid directed towards the endothelium can cause a focal point of decompensation the next day. Check for residual epinucleus and cortex is very important, especially if you've done a hard cataract. For example, the small bit may fall down after 2 or 3 months and it forms in the anterior chamber and it slowly gives rise to decompensation. And of course, careful IOL implantation, the bag always advisable with a lot of visco inside. And it goes without saying that intracameral adjuvants should be used minimally. Ringer lactate should be avoided. Balanced salt solution is always cornea friendly, so you can use that. If you're using a trypan blue, it should be minimal, very minimal. 1 or 2 drops over the surface itself is enough under an air bubble. And try to avoid intracameral epictrate and lignocaine. Instead, go for a stretch pupilloplasty, or as is shown, the Kugelin hook or iris hooks. And very important to clear the visco post-operative, before the closing the case. So essentially, I would like to say that SICs in compromised cornea is doing safe surgery. That's all. You just preempt all the problematic steps which can arise, and as a routine, try to practice all these steps like bimanual and especially the bimanual nucleus prolapse and delivery in all routine cases, so that you don't land up in problem later. Thank you.